the House Human Services Committee and the Senate Public Health Committee. Clerk, please take the roll for the House Public Health Committee.
Start with this. Yes. Stava Murray.
Here.
Evans. Here. Miller. Canty. Hodder. Lilly. Ma. Morris. Here. Schmidt. That's 3 for public health.
Clerk, please take the roll for the House Human Services Committee.
Moeller. LaPointe.
Here.
Hammond. Cassidy. Haas. Here. Hernandez. Meyer. Morris. Here. Ness. That's 3 for Human Services.
Clerk, please take the roll for the Senate Public Health Committee.
Senator Severson, Senator Chesney, Senator Lewis, Senator Ventura, Senator Murphy, Senator Collins,
Recording in progress.
Leader Hunter, Senator Villa.
Present.
There are 4 committee members present for Senate Public Health.
Thank you. This is a subject matter hearing about Lyme disease. As a reminder to everyone attending by Zoom, please keep yourself muted throughout the hearing unless you are speaking. Have your camera on if you are speaking, and use the raise hand function on Zoom if you have a question. Additionally, this hearing will have a hard stop at 11 a.m., so I would ask all members and witnesses providing testimony to keep that in mind. With that, I will have some very brief opening remarks. I would like to thank everyone who is here today to testify, as well as thank Representative Swanson for putting together the panelists for today and doing the hard work there. So thank you very much. We have our first panel of experts, which include Dr. Chris Stone, who's lab director of the Illinois Natural History Survey Prairie Research Institute in the University of Illinois. We also have Dr. Roberta Van Zant, the Van Zant Medical Group. We have Dr. Samuel Shore of Internal Medicine, who is of the Asperus Tick-Borne Illness Center of Excellence, and Dr. Jolene Carr. We can start with Dr. Chris Stone.
All right, good morning. Does that work? So thank you very much for this opportunity. I am, as I said, the director of the Medical Entomology Lab at the Prairie Research Institute, and we work broadly on research and surveillance of vectors and vector-borne diseases. So I was asked to provide some comments on what my lab has learned regarding ticks and the pathogens they carry in the state over the past few years. So our work on this topic started back in 2018, and at the time it was becoming clear that tick-borne diseases were a growing threat. So nationally, between 2004 and 2016, the number of cases of tick-borne diseases had doubled, and reported cases in Illinois likewise saw a strong increase over that time period. So as Illinois had been lacking a systematic tick surveillance program at the time, our lab then started working on this with support and in collaboration with the Illinois Department of Public Health. And over the past 4 years, working with a range of partners, we collected and identified over 13,000 ticks and tested over 9,000 of them for multiple pathogens. So a large focus has been to document the presence and establishment of the black-legged tick in the state. So this is the tick that can carry the pathogen that causes Lyme disease. This species has been increasing its range southward, and we have detected it in 61 counties and found it to be established throughout large parts of northern and central Illinois. So overall, we found that about 39% of the adult ticks and 22% of the nymphs were positive for Borrelia burgdorferi, so the bacterium that causes Lyme. We found they also carried a number of other pathogens, including another Borrelia species, Borrelia miyamotoi, and detected for the first time in the state the presence of a parasite, Babesia microti. So knowing that these pathogens are present and that people could be exposed to them here in the state, I think is helpful and important information for healthcare providers to be aware of. We found a new species in the state, the Gulf Coast tick, was established and in places highly abundant, particularly in southern Illinois. So this is also a species of public health concern. It can spread the agent of tidewater spotted fever or R. parkeri rickettsiosis. We found that approximately 21% of the Gulf Coast ticks we collected carried this pathogen. And this species of tick can be found in environments that are quite different from where we find other ticks. So this is, I think, also important for people to be aware of. The Lone Star tick, whose bite is associated with alpha-gal syndrome, or the red meat allergy, also appears to be expanding its range further north and is abundant in large parts of the state. After the first 2 human cases of Heartland virus were recorded in Illinois in 2018, a year later, in collaboration with IDPH and CDC, we found this virus to be present in ticks in the state as well. So overall, we have shown these species to be more widely distributed and established throughout the state. We found a number of important new pathogens that had not previously been documented in ticks here. And we found that some pathogens are present at high levels in ticks in Illinois. So more recently, with support from the University of Illinois NCSA, the National Center for Supercomputing Applications, the Illinois Lyme Association, and IDNR, we've been expanding our work on community-engaged passive tick surveillance. So this means rather than us going out to collect ticks from the environment, we work with citizens, outdoor workers, and other scientists and ask them to send ticks that they find on themselves, a family member, or animals, and send them to us so we can identify them and then for some of them test them for pathogens. So we think this adds or complements the active surveillance in a number of helpful ways. For instance, by being able to locate ticks in areas where finding suitable collection sites might be challenging, or finding ticks way outside the range where you would expect them. So an example of that would be the Gulf Coast tick, which we picked up through a passive submission in DuPage County, so much further north than we had expected that tick to be present. And we pick up a wider diversity of tick species as well. So one example there is the groundhog tick, or Ixodes cookii, which is a vector or involved in Powassan virus transmission. And that was found by a member of a forest preserve district who sent that in to us. We're also developing collaborations with other scientists, including people at the Field Museum and Illinois Extension, to collect ticks from animals. For instance, working with veterinarians and cattle producers, really with the aim to increase our chances of early detection of the Asian longhorn tick, so an invasive tick species. And then we've been developing a website to allow people to report tick bites and initiate submissions to us. And we think that that really offers an opportunity to learn more about the types of activities people tend to be engaged in when they encounter ticks, the types of locations where they find them, and what they're already doing in terms of preventative measures. And then by engaging citizens directly in tick submissions, we can at the same time raise their awareness of tick exposure and prevention methods. So thank you.
Thank you. Clerk, please add to the roll appearing virtually Representative Canny, Representative Lilly, Representative Ma, Representative Schmidt, and Representative Hodder. Our next, we're at the end of the panel. Our next panelist is Dr. Roberta Van Zandt from the Van Zandt Medical Group.
Thank you. Thank you for having me today. My name is Dr. Roberta Van Zandt. I have my own practice in Morton, Illinois, outside of Peoria. and I have been practicing since 2003. I am a family practice physician, and so I see a variety of patients, adults, as well as children. And I have been really focused on a treatment identification of tick-borne infections since approximately 2012. Of course, this got started by some own personal experience with a family member who was misdiagnosed approximately 10 years prior. He was quite sick and did not have any diagnosis at the time. Subsequently found out that he had Lyme and Babesia. Babesia infection is actually present here in Illinois, but it hasn't been well recognized. And that was actually his primary diagnosis when he initially got quite sick. And a little bit on the background there, he actually saw an infectious disease physician when he was ill and requested to be checked for Lyme disease because he had quite a few tick bites in his life as he was a hunter. And he was told Lyme disease doesn't exist here, and he was actually never tested and developed quite a few health problems as a result of that. So I personally got interested in Lyme disease because of my relative, but subsequently started looking for it in my ill patients who didn't have an easy explanation for their symptoms, and really that blew the door open. So I'd like to just tell you about my experience seeing patients here in Illinois. Easily 50% of my practice is comprised of patients who have had some sort of tick-borne illness as a contributor to their symptoms. It has been termed chronic Lyme disease. However, I'd like to say it's just previously undiagnosed tick-borne infections. These tick-borne infections, Lyme, Bartonella, Babesia, Rickettsia, tick-borne relapsing fever, Anaplasma, Ehrlichia, have all been documented in Illinois in the ticks. And indeed, we see them on testing of our patients who come in with a variety of symptoms, fatigue, joint pain, migraines, neurologic disorders. And after treating, a majority of the patients have, if not complete resolution of their symptoms, rapid improvement. But the concern really is with the lack of information that is being given to the providers to recognize that infections may be present in these patients who have chronic disease and long-term issues that have been swept under the table. Indeed, I had a child who had a obvious bullseye rash, erythema migrans rash from a tick. However, when the parent called it in to report it to the public health department, they were told it couldn't be recognized because it wasn't big enough. It had to be 5 centimeters or greater. And so it wasn't even recognized as a tick bite, which had caused a local infection because of the poor diagnostic criteria. So, even when we are trying to recognize and report, it's being underreported because of the very strict criteria that is involved here in Illinois. The lack of education of physicians from the awareness that, we believe or are taught that Lyme disease and other tick-borne infections are here is really a driving force, I believe, behind the lack of early intervention and treatment. Rashes that are blown off or maybe not even recognized as a potentially tick-borne, or symptoms in the right period of time for active ticks in the spring and summer. Symptoms that seem to be out of line and are misdiagnosed as a viral illness, but there's not really a surge of viruses in that time. Those are the things that are being overlooked when patients come in, and that physicians need to be better educated on. We need to be talking about this in our medical societies, at our conferences. We need to be supporting this because we have a whole generation of people that are walking around ill that could be treated. And unfortunately, this also affects children. And in children, it affects them in different ways. They don't present in a way an adult might with pain or fatigue. They're presenting with neurologic symptoms. And indeed, we see a huge number of children coming in with new onset issues with depression, anxiety, tics, behavior disturbances, and they test positive for tick-borne infections and are miraculously, per their parents, cured when treated appropriately. So this is something that pediatricians need to be aware of too when they're addressing children and different symptoms there, as opposed to being shipped off to psychiatrists. We have a huge epidemic of mental health disorder in the pediatric population. And my belief is that a large part of this is due to underlying infection. And I would be remiss if I didn't talk about the impact COVID has had on reactivation of these infections. The COVID epidemic has brought a lot of people out of the woodwork with new symptoms that they never had before COVID. And indeed, we know that the infection is an immunosuppressive infection and allows these previously undiagnosed infections to come out. And this is a whole different approach to medicine, which is the recognition that, we are not sterile. We have been exposed and indeed carry underlying infections in us, which is well understood in the world of viruses such as shingles and varicella. But we need to be better educated across the board and bring this to light with our providers, physicians, nurse practitioners, PAs, and all areas of primary care, gynecology, pediatrics, family practice, internal medicine, so that we can start helping people earlier and recognize them appropriately. Thank you for your time today. I appreciate the opportunity to talk.
Thank you. Clerk, please add Representative Hammond and Representative Meyer to the roll. And our next witness will be Dr. Samuel Shore.
Thank you for the opportunity to speak today. I am licensed to practice medicine in Illinois and have several patients that I follow accordingly. I'm primary care medicine trained and have been in practice for about 40 years, associate clinical professor at GW University. My interest initially was that of fatigue, which evolved into my connecting Lyme disease being responsible for many patients with fatigue. I've presented to congressional staffers. I was a member of Virginia Governor's Task Force on Lyme disease, past president of ILADS, and am published individual independent research and am the lead author in the consensus definition of chronic Lyme disease. As mentioned, chronic Lyme, or as mentioned, Lyme disease is due to the organism Borrelia burgdorferi. It is the #1 vector in the United States and in Europe. In fact, CDC claims that the number of Lyme disease cases reported in the United States has doubled since 2000, and the number of counties considered endemic or high risk for Lyme disease has tripled in that period of time, and Illinois is in that category. I look at this condition as having somewhat of a perfect storm. If you think about the very small vector, which is the tick, the form of the tick that is most likely to transmit is the nymph, and that is the size of a pencil tip. That very often is otherwise not identified. In a study of over 1,700 children with bona fide Lyme disease, 18% remember being bitten by a tick. There was mention of the erythema migrans bullseye rash, and there are ranges as different studies from 20 to 80% of individuals with acute Lyme disease present with an EM rash. And on average, where it's been published in the 50% range, and very often it can be atypical or in a location that an individual may not be able to see, behind the ear or elsewhere. There are an increased number of ticks that are infected both by Borrelia and, as mentioned, by other pathogens that can cause disease in individuals, and that can cause presentation to be more complex and the treatment of those individuals more challenging. The presentation in acute Lyme disease could be seen as a nonspecific viral presentation, albeit usually in the early summer, late summer time frame, but it can be a nonspecific viral-like presentation. Chronically ill individuals, as mentioned, very often present with common symptoms of fatigue and pain and sleep disorders. But there is well established in the literature that chronically ill individuals with Lyme disease can have a long-standing significant decrease in their quality of life. This is a very smart organism. It, for example, can sense a toxic environment so that if we treat with penicillin-like medicines, which have the ability to disrupt the cell wall, the organism can shift into a cell wall deficient form called a persister cell, survive the presence of that penicillin, and then shift back into the more active spirochetal cell wall form when the penicillin is no longer there. It can cause immune dysregulation, which can have bearing both on the ability to test for the organism as well as treat the infection. And in fact, one of the problems that we have is that the standard test that's promoted by the CDC, the two-tiered system, is in an order of 50% sensitive. So every other individual with real Lyme disease may present with a negative test. In fact, the sicker one is, the more disrupted their immune system is, the more likely their blood test will be negative. That's what we call seronegativity. This is a very controversial topic within the infectious disease community and has taken on a political twist such that many in the medical community prefer not to see Lyme disease patients because they just don't want to have anything to do with them. A good example of a controversial phenomenon that is recommended is the prophylactic treatment of an individual who has been exposed to a tick in order to prevent the transmission of disease. And so that's what we want to do. We want to prevent the disease from being transmitted at all. The recommendations by the CDC are a single dose of 200 milligrams of doxycycline. That was based upon a 2001 study by Nadelman, whereby they used as the successful criteria no development of an erythema migrans rash after 6 weeks. Well, we already know that 50% of people with Lyme disease don't develop an EM rash to begin with. So that type of criteria was, and many feel, is inappropriate. The second criteria was no symptoms within 6 weeks. It's well established that symptoms after exposure to Borrelia may have a several month and even longer period of time of incubation before the symptoms are manifest. So we already see that there are recommendations promoted by organizations that are reputable, but that are of questionable value. And we need to clarify those controversial areas. We need to teach and instruct our young physicians as I did a couple of years ago to a Northern Illinois residency group. And we need to have an open mind to recognize that there are many ill people out there for whom we would like to have improved outcomes. Thank you for your time.
Thank you. Our final panelist for this first panel is Dr. Jolene Carr.
Thanks for having me. I'm Dr. Jolene Carr. I'm a family medicine physician, and I work at the residency program at, through UEComp in Peoria, Illinois. My story, I really appreciated Dr. Van Zant's statement. Likely our story started during COVID, during the lockdown, and we started taking our two sons hiking regularly in Detweiler Park and our neighborhood park in Edwards, Illinois. We currently have an 8-year-old little boy. He's super hyper, he's highly gifted, a sweet little boy, but our problem started when he was 6, and at the time he was going to a kindergarten, and he started with escalating issues. He'd always been hyperactive, but he started having new severe hyperactivity, arguing with teachers, oppositional behaviors, new rigidity, new anxiety, numerous meltdowns, separation anxiety. And in one particular week in May of 2021, he started all of a sudden with obsessions and compulsions. I will never forget that week. That's when he started to feel upset by the feel of my breath on his face, the feel of his clothes, and anything food-related gave him a severe anxiety attack and a meltdown. And he was also constantly running to the bathroom to urinate. I had heard of PANDAS as a family medicine physician, which is pediatric autoimmune neuropsychiatric disorder associated with strep. So I had his blood drawn and his throat cultured, but they both came back negative. So we were without answers, and we continued seeking answers for his, as we called it, ADHD and OCD. We saw his pediatrician, a child psychologist, a child psychiatrist, a functional medicine doctor. We started numerous supplements for anxiety. We started prescription meds for ADHD and anxiety. We tried neurotherapy. He had a 1-to-1 aide at school. We did occupational therapy, and we did exposure and response therapy for OCD, and all with little help. His symptoms continued for months, and after a while we found a clear pattern where his behaviors would escalate right before any viral infection, and then they would settle down a little bit once the virus had passed, but he always had baseline issues. And every doctor I brought up to that, including myself as a physician, I didn't really have an answer. The ramifications of his behavior were excruciating. We were told we were ineffective parents. He got kicked out of his private school. He lost friends. Our family lost friends. We were judged by family members, neighbors, and teachers. He was constantly anxious. He had to have a 1-to-1 aide at school, and then he was moved to a specialized classroom. His self-esteem and his self-perception of who he was significantly affected. Our family experienced extreme stress. We were told he had a developmental disorder, a psychiatric disorder, or that he lacked empathy, or that he was simply a defiant child without proper discipline. And eventually, through reading, I learned more about the sister diagnosis to PANDAS called PANS, P-A-N-S. Pediatric acute onset neuropsychiatric syndrome, which is not from strep like PANDAS, but instead can be a variety of different etiologies. The symptoms are very similar to PANDAS, such as new onset OCD or tics and eating restrictions, anxiety, sensory and motor abnormalities, behavioral regression, deterioration at school, mood problems, and urinary symptoms and sleep problems. So the thinking is the body produces antibodies against Lyme, the Borrelia bacteria, that get confused and then have an autoimmune response and attack certain receptors in the basal ganglia that share certain DNA sequences in common with the Borrelia bacteria. And this autoimmune process is called PANS. Which sounded a lot like what my son had. But when I read through all the etiologies of PANS, nothing really resonated with me. Things like mold, mycoplasma, and Lyme. And I thought Lyme wasn't something a child in Central Illinois would be affected by. Finally, we made the decision to see a nationally known specialist in the area of PANS and PANDAS in Washington, D.C. Her name's Dr. Elizabeth Latimer. She ordered a bunch of tests, and the Cunningham panel, which is a panel for PANS and PANDAS, came back positive. We flew our family out last fall to Washington, D.C. to see her. And the first day of our visit, she handed me our IGeneX report, which is a panel for tick-borne illnesses, and it was positive for Lyme disease. I was speechless and shocked. I told her Lyme was not something we saw in Illinois, not like the northeastern U.S. And she literally laughed at me and said, it's because we aren't testing for it. So she gave us a care plan of long-term doxycycline, and after 5 weeks, we started to see some improvement in my son's behavioral charts at school. And just 1 week ago, we finally infused the expensive medication of IV immunoglobulin to address the autoimmune process of PANS. So our story is still being written. It's hard to say if it's going to be an easy or a hard road. We assume my son has had Lyme for probably over 3 years before he was diagnosed. We never saw a classic rash. I'm a physician, and I was vastly undereducated about the local prevalence of Lyme, and I didn't even know about the presenting signs of PANS. And so his pediatrician was undereducated and misdiagnosed his case, as well as his child psychiatrist and his functional medicine MD in Chicago. Yet, had I not had a career in medicine, had our family not had financial resources, had we not known how to advocate for him, we probably would have been in a very different place. Not addressing Lyme as the epidemic that it has become, and not giving public awareness and medical legitimacy to the diagnosis of PANS not only makes the road to healing longer for those diagnosed with the condition, but it leaves the medically underserved voiceless and misdiagnosed. So we desperately need enhanced surveillance of tick-borne diseases. We need public awareness and education of the prevalence of Lyme. We need medical professionals to be aware and educated. We need effective and accurate testing and more clinical trials on best treatment practices. For us, our healing has already started. It started before we even started his medications. It started the day we met Dr. Latimer in Washington, D.C., and we were finally given a name for our diagnosis, Lyme PANS. And that's the day we finally felt heard. Thank you.
Thank you. Do members have any questions for these witnesses? Senator Murphy.
Thank you. And thank you, doctors, for your presentations today. We're really appreciative of that. I'd also like to thank the co-chairs for conducting this joint task force, because a number of us have been serving on a Lyme disease task force for well over a year. And we're getting really frustrated that we're not feeling that we're making any progress. So I really commend the chairs here for having this meeting. I think that a number of us have the understanding, and I'm so glad to hear you all say, that Lyme is everywhere. It's in so many non-traditional locations. And we have physicians that think that it's only coming out of very rural, woodsy environments, and that is not the case, because I represent an area by O'Hare Field, and every time I talk about this, another one of my constituents tells me how they got Lyme disease, and they live in a very, very urban area. So my question is, our job on the task force is to help the department develop policies that will make an impact on this. So do we need to have mandatory continuing education credits on every physician's licensure? Is that going to be helpful? Are we, and anybody can answer these or take a part of it, Do we need to have the checkoff box on the physician annual examination form where we add a number of things on that? Do we have to add that to that criteria? And then what's the best solution for training our ER doctors, who often are the first point of contact? And whoever wants to answer, it's not directed to an individual. Thank you.
I can comment a little bit on the the idea of mandatory education. I mean, I always balk a little bit at the idea of mandatory anything to all physicians, because it may not be important, but we have a mandatory opioid CME requirement now, and I don't even see patients who would need that, as a majority of providers don't. And I certainly think that, something along those lines where maybe not every physician, but I like the idea of requiring some type of education, perhaps within the medical conferences that are in Illinois, that, there needs to be some type of option for providers, just putting it before providers to be aware of in recognizable conferences and establishments legitimizes it. I think Dr. Carr wonderfully told her story about how she I did not recognize this. I was trained out on the East Coast, and I don't think I was ever told about the importance of Lyme disease, even out there when I trained. And so for sure, when I came to the Midwest, I didn't think about it. And it's about physicians providers recognizing that this is a legitimate issue. And to do that, it has to be addressed in legitimate places, such as medical conferences, and it needs to come from the state, recognizing that this is a legitimate healthcare burden in the state, and it's causing unnecessary medical expenditure for for these chronic issues that we have no better answer for, when patients could be healed and improved, and take the burden financially off the healthcare system to continue to just help these crippled patients along with no answers. So I do like that idea about trying to put this somehow in legitimate forums, so that more providers acknowledge that it is here.
I might like to add that not only do we need to educate, but we need to review what we're educating. The content of those areas of review for clinicians needs to be overseen by those of us who have a more realistic perspective of what really exists. So a 5-centimeter EM rash is not necessarily required. It could be 1 centimeter, but according to the CDC, that doesn't count. Yet it's probably representative of acute Lyme disease. The example that I gave in relation to prophylaxis, that needs to be reviewed, because what we don't want to do is perpetuate information that is old and frankly not accurate. But I agree, we need to educate clinicians.
I have something to say. And circling back to mandatory physician education, a lot of times as a physician, you kind of feel like there's more stuff piled on you, and so another, thing to do. But I don't think the education necessarily has to be lengthy. I mean, I can't count the number of my colleagues that I've told my story to that didn't even know what PANS or PANDAS was, and especially would never have made that kind of connection with Lyme. And even, a very short information would be enough, I think, to educate physicians. And another thought is that PANS, in particular, I mean, in my son's case, it was a lot of behavioral issues, but for teenagers, sometimes you're seeing teens that are acutely suicidal, and actually a great majority of adolescents with PANS or PANDAS are suicidal, and I don't think that is even being addressed, in an acute setting, whether that's ER, or the psych floor, et cetera. So I think there is a sense of urgency to have that education.
I do agree with Dr. Shore that what is being taught is paramount, because there are several ways that providers need to understand this, and primary recognition of the infection in early stages with acute new symptoms. You could save people a lot of headache if you just were able to acknowledge that in the early phases there can be a lot that's done. So recognizing that is important, but the chronic aspect of it, or the chronic symptom aspect of it, also needs to be recognized. This is where conventional medicine does not do a good job of educating physicians and helping with our healthcare burden of chronic disease. I do think that we are always seeking funding for these things, and this, of course, is something that the Lyme Disease Task Force has asked and has tried to work with, is to seek more funding to test ticks, et cetera. But certainly it seems reasonable to look at, if we're going to fund things, funding education, funding, putting together providers who understand this problem to educate other providers, and have these providers be the ones who are going to the conferences, having tables at conferences to educate. I know that the Illinois Lyme Association does a great job at this, but they are small. They cannot be everywhere at one time. So, funding to provide education is paramount. And I think that needs to be addressed, is how do we get state funds allocated to educate providers? We talk a lot about educating patients and making them aware. That's important. But if they go to providers who blow them off, then that education would have been better spent. Those funds would have been better spent to help educate the providers to whom the patients are going to. Because honestly, patients know it's out there. They're just looking for the providers to diagnose them.
Thank you. Representative Hodder with a question.
Thank you very much, and thank you to all the panelists and physicians that spoke. Dr. Carr, I am also a professor of emergency medicine and anesthesiology at University of Illinois College of Medicine, Peoria. So thank you for coming. I've been a practicing emergency physician since 1997, and I can tell you that I've seen a lot more than I've diagnosed. It's a difficult diagnosis to make. But I will just say here right now that the answer is not state-mandated CME, all right? It's such a lazy response to a disease. And what it is the answer is more education, more awareness. But when you start to say the General Assembly is in charge of our CMEs, then we see what's happening. And we are in highly high technology, highly changing. The literature is changing at all times. There's many, many infectious diseases out there. And so what happens is whatever the disease of the day or of the year gets to choose what we are mandated to be educated on. All the other things and all the other literature and all the other patients are hurt by that. So I am all for education, and I'm 100% behind you, and you will have an ally in educating emergency physicians, pediatricians, and family practice doctors. If we can target them, instead of saying what the easy, lazy fix is, we'll just make it a CME requirement at the state level for all doctors. And then you have pathologists and anesthesiologists and radiologists all having to take that, all unbelievably, upset that they have to not take the continuing education in their field, and their highly changing field, and all the literature out there, but what the General Assembly decided that you should learn. So I am all for education. Thank you for coming, and I hope that, this raises awareness in me. And so if we can target those specialties and awareness in patients, to bring it up, because it is such a it's a fooler. It fools you. And most of the time, it's fever, it's malaise, it's joint aching. I see 100 patients like that. And am I going to test every one of them for Lyme's? Am I going to start them on Doxy? No. And so I probably, like I said, I've seen a lot more than I've diagnosed, and it's usually a diagnosis of the third visit, or like you're saying, extended diagnosis. Anyway, thank you for coming.
Thank you. We're going to move on to our second panel in the interest of time. Our panel 2 patients and advocates include Lauren Russell, Josh Shaw, Susanna Warner, and Jen Russell, the Executive Director of the Illinois Lyme Association. First up is Lauren Russell.
You guys go ahead and go back. I've got an introduction. Oh, sure. Okay. Thank you, Madam Chair. Before the group gets started here, I just want to highlight within the last couple of weeks that the National Department of Health and Human Services came out with their report on prevent and control of vector and borne diseases. And to kind of lead into what these panelists are going to be talking about, I just want to read a paragraph out of here. This was put together by many federal agencies, Department of Ag, the Department of the Emergency Management Agency, just a whole list of groups of Department of Defense, Department of Ag, EPA, Department of Interior, Department of Commerce, and they've all put together this report. One of the paragraphs says that Lyme disease caused by Borrelia burgdorferi is the leading cause of the tick-borne disease, accounting for more than 8 out of 10 reported tick-borne diseases cases annually. However, reported cases are only 6 are a fraction of the diagnosed and treated cases. Recent estimates suggest that approximately 476,000 people are diagnosed and treated for Lyme disease each year in the United States. A June 2022 study estimated the total societal costs incurred by patients, healthcare systems, or third-party payers of diagnosed Lyme disease ranges from $345 million to approximately $1 billion. So it's a big issue, and it's costing our families a lot of money. It's costing businesses a lot of money from missed work. And so I will move on to the panel. Lauren.
Thank you, Chairwoman Vila, LaPointe, and Stava Murray, Representative Swanson, and Leader Murphy for bringing us all together today to discuss a very important issue of Lyme disease. Hello, my name is Lauren Russell. I'm from Mercer County, and I have Lyme disease. 6 years ago, I came to the Capitol to share my story to the 100th General Assembly. Because of your support, we passed the Lauren Russell Lyme Disease Prevention and Protection Law, which was the state's first critical step. Lyme disease is the fastest growing infectious disease in the United States. Over 200 kids are infected every day. That's 4 school buses full of kids. I'm here again today asking for your help on behalf of all Lyme sufferers in Illinois. When I was in first grade at 7 years old, I came home from school, got off the bus, and suddenly my legs wouldn't work anymore. I became extremely exhausted, and I had to lay down in the driveway, and my mom had to carry me inside. From there, things started to decline rapidly. I had a fever, started throwing up blood, which landed me in the ER. All they found was a mild ear infection, and they decided to send me home. My gums and nose started to bleed severely, and I had swollen lymph nodes. Blood tests showed I may have leukemia because my white blood count was so low, and they scheduled for a bone marrow procedure. Thankfully, a last-minute blood test showed my white blood count came up slightly, so they sent me home with no answers. After having a fever for about a month, I was finally able to return to school, but my story wasn't over. In second grade, I woke up one morning and I couldn't remember anything. I couldn't remember the day before, and I could no longer do simple kindergarten math. I had lost most of my short-term memory. In third grade, I started experiencing some sort of seizures, and they decided to remove my tonsils and adenoids, thinking it was holding infection, and there was no change. In fourth grade, the fatigue I was experiencing was so bad I was barely able to leave my bed. The days that I did, my teachers just let me sleep at my desk. One day I developed 3 bullseye rashes in my armpits, and no one believed it was Lyme, saying Lyme disease wasn't in Illinois. I kept getting worse, and at this point I was living on pain medication. I could no longer do schoolwork because I forgot what we learned by the time I had gotten home, and I still had no answers. One day my dog just started crying and dragging his back legs, and he had the same bullseye rash as I did, and he was quickly diagnosed with Lyme disease. Still, no one would take Lyme seriously, and one doctor even accused me of doing the bullseye rashes to myself simply for attention. Another doctor finally gave me 10 days of doxycycline, and my symptoms started to go away. But they quickly came back when I finished the medication. I was tested for Lyme twice, and they both came back negative. We found a doctor more educated on tick-borne disease, and I finally received my actual diagnosis through a positive test. I was undiagnosed for 3 years. I have seen 16 doctors, and I've been in treatment for 4 years. Unfortunately, I will never be considered a counted case because I was not diagnosed acutely. Thankfully, I'm doing great now, but my life has been forever changed. No one should have to suffer and have to fight to simply be believed in. I don't blame the doctors. I do believe most of the ones I encountered were doing the best that they could with the knowledge that they had. However, it is time we change, and it is time we educate. Members of the committee, I come today to ask you for your help once again. Lyme disease needs to be a priority in Illinois as more are encountering ticks and going undiagnosed. There are 2 bills this session that I ask for your support in passing. In May, you passed SB 1803, the Lyme Innovation Act. This was a very important step. This act sets up a plan to combat tick-borne disease. However, it was subject to appropriations. Senate members, I ask that you please support and please co-sponsor Leader Murphy's bill, SB 3231. It develops a Lyme disease awareness lottery ticket, and this can be used to raise money in a voluntary way, and it doesn't tax the people. House members, Representative Swanson has a school nurses bill, HB 4274. I please ask for your support and co-sponsorship as well. Connecticut recently passed this bill. Lyme disease is real, and it can be a very serious, debilitating disease. You can take it from someone who's lived with this for almost 11 years. In my county, several high school cross-country kids got into a nest full of ticks, and the coach just simply ripped them off and threw them away. It is now too late to test those ticks, and we now have several kids who have no idea if they were potentially exposed to this. We must have a plan in place. So in closing, I want to thank you all for all you've done for Lyme patients for these past 6 years. Thank you for listening to our stories and taking action and putting Illinois at the front of the nation. You all are the true champions, and I thank you.
Thank you. Our next panelist is Josh Shaw.
Hello, my name is Josh Shaw. I live in Plainfield, Illinois. My Lyme journey started back in May of 21. I was bitten by a tick, and I didn't have a bullseye rash, nothing like that. I wasn't educated on Lyme. I didn't know anything about it, so I just kind of brushed it off and moved on with life. Fast forward 4 months later, I started getting symptoms of twitching, muscle exhaustion in my left arm. Again, I ignored it. It didn't bother me on my day-to-day basis. So, fast forward a year later to 2022 in the fall, I started really noticing that it had spread throughout my arm and that my arm was getting weak. I decided to go see a doctor, and I ended up seeing a few neurologists, did some physical therapy, and nobody seemed to know what was going on until I seen another neurologist who sent me down a path of ALS, a possibility of ALS. I went to Rush and Northwestern Hospital to see some specialists in ALS. January of 2023, both after many tests, both hospitals diagnosed me with ALS. I wasn't accepting that, so I went to Mayo Clinic to see their ALS people, came out with the same diagnosis. Anyways, I ended up doing some research on my own online just to try to help myself with ALS. I came across a story similar to mine where a girl in her 30s, had been diagnosed with ALS, ended up being Lyme disease, and with the proper treatment got better. I brought this to my doctor's attention at Northwestern, and he basically told me to stay offline and stay off the internet. That brings me to the summer of 23, where I went out on my own, found a doctor who was Lyme literate, and got me, did some specialty labs on me, and did a bunch of different testing, and ended up coming back with a positive Lyme test, and also 2 co-infections, Bartonella and Babesia. Since then, I've been treating with a Lyme literate doctor since September. My symptoms are getting better. Like most Lyme patients know, it's not an overnight fix. It's a very long road. But like I said, my symptoms are slowly going away, and I feel with continued treatment that I will end up better in the end. I have also found, with this diagnosis, I've also found other people in Illinois with the same story as mine, just through telling my story. Other people bringing it to my attention that friends of theirs had the same thing going on, same diagnosis, ALS, ended up being Lyme disease. So there are more people out there in Illinois and across this nation. And that's my story. Thank you guys all for coming and listening to our stories.
Thank you. Our next witness is Susanna Warner.
Hi, my name is Susanna Warner Torres, and I come to you in my 27th year of battling persistent Lyme disease and tick-borne co-infections. First, I'd like to say thank you to Chairwoman Vila, Chairwoman Stava Murray, and Chairwoman LaPointe for your time today. Thank you to Leader Murphy and Representative Swanson for your continued efforts and advocacy on behalf of tick-borne disease patients in the state of Illinois. I contracted Lyme disease and other co-infections as a 12-year-old cross-country runner in East Central Illinois. One day I was a healthy, athletic child. The next day I could barely get out of bed. I couldn't recall seeing a rash or a tick bite. For 18 months, my courageous parents, who are here with me today, sought answers as I rapidly deteriorated in front of their eyes. I was referred from one doctor to another within our local health system. Thanks to the research and resources of my family alone, I was diagnosed by a Lyme specialist in New York. He based my diagnosis on clinical presentation and patient history. Months later, Lyme bacteria were detected in my system via PCR tests by 2 separate labs specializing in tick-borne diseases. Today, I continue maintenance treatment under a Lyme specialist in Virginia, Dr. Samuel Shore, who testified earlier, while local doctors attempt to manage my persistent symptoms. After years of being severely cognitively impaired, bedridden, and dependent on a wheelchair, I am fortunate enough to be employed as a teacher after dropping out of high school and to support the amazing efforts of the Illinois Lyme Association as they bring change to our state. However, I live daily with the consequences of delayed diagnosis and treatment, which manifest mainly in severe neurological and arthritic symptoms, along with fatigue. Multiple members of my family have contracted tick-borne diseases in Illinois. We are grateful that they each presented with the typical rash, and our family had the awareness and determination to get them treated in a timely manner by any means necessary. However, my story is unfinished. I married my husband, Wilfredo, in June of 2021, who's also here with me today. Soon after our marriage, he began to take an avid interest in fishing, as men will do. In the summer of 2022, Will started to display odd symptoms: migrating joint pains, fatigue, eye floaters, tinnitus, one thing after another. After 18 months of trusting local doctors for answers while watching my husband deteriorate, I could no longer ignore my gut instinct. I had to know, did my husband have Lyme disease? Sure enough, he tested positive with a specialty lab and is now under the care of my Lyme specialist in Virginia. When my husband returned to our state of Illinois with a clinical diagnosis from a renowned Lyme expert and a positive blood test, his primary care doctor in Illinois was skeptical at best and dismissive at worst. This man was more concerned about the damage an antibiotic could do to his liver than the systemic havoc wreaked by a tick-borne disease. I was absolutely devastated to realize that nothing has changed in Illinois, even 27 years after my journey began. I have lived both sides of this story. I have known the anguish of watching a loved one deteriorate while desperately seeking and praying for answers. I also live in a body that continues to challenge me with constant pain and fatigue as a result of tick-borne diseases. My own story preceded my husband's experience by decades, yet there are many similarities between our cases, mainly that doctors in Illinois continue to lack awareness and education and typically do not consider tick-borne disease as a diagnosis or effectively treat it. For the medical establishment in Illinois to recognize this problem, state and federal agencies such as the Illinois Department of Public Health must begin to step up. We are here today to testify that they have not done so. My prayer is that the day will come soon when the nightmare my family has experienced with tick-borne diseases will not be repeated by families across the state of Illinois. Thank you for your time.
Thank you. Lastly, we have Jen Russell.
Good morning. Thank you, Chairwoman Vila Lapointe, Stava Murray, Leader Murphy, Rep. Swanson, and members of the committee for your support in putting together this hearing today. I am Jennifer Russell. I'm the Executive Director of the Illinois Lyme Association. ILA has 1,800 members and growing across the state. Tick species and related pathogens are rapidly expanding geographically in Illinois. In 2012, Yale University listed Illinois as an emerging risk state for tick-borne disease. The CDC issued a warning to medical providers, including Illinois, to be on alert for tick-borne disease in 2017. As Dr. Stone indicated, ticks are expanding both rural and urban settings. Lyme disease is the most common tick-borne disease, but other tick-borne diseases are also an urgent public health concern, like alpha-gal. The anaphylactic allergy to red meat is widespread in Illinois. The Asian longhorn tick will soon be in Illinois and imposes a significant threat to our cattle. The prevalence of tick-borne disease is underreported. The Department of Health and Human Services just released their National Strategy Vector-Borne Disease Report, and it estimates 476,000 people in the U.S. are diagnosed and treated for Lyme disease annually. The BMJ Global Health published a study stating 14% of the world's population likely has or at some point had Lyme disease. The CDC surveillance criteria requirements are very restrictive. Additionally, only acute cases are counted, meaning the person was bit and diagnosed immediately. Patients diagnosed at a later time are not a recorded case. According to LymeDisease.org, it takes an average of 3 years to get a Lyme diagnosis. This leaves a majority of people unaccounted, and this is the crux of the problem and why Lyme has not gotten the attention it deserves. Reported cases often drive funding and other support. Governor Pritzker once asked me how many people in Illinois have Lyme disease. Most patients in the ILA community are not counted cases, similar to the ones that testified today. Since 2012, IDPH reported approximately 3,100 Lyme disease cases. The CDC admits these cases are underreported by tenfold. Conservatively, 31,000 people have contracted Lyme disease in Illinois since 2012. I note conservatively because some studies indicate that the underreporting could be much higher than tenfold. In 2022, IDPH only reported 239 Lyme cases. We know that is not even a glimpse. I contacted 2 CLIA-certified labs that specialize in tick-borne disease testing for this hearing. Combined for 2023, they reported 685 positive cases, with an additional 443 suspected but not confirmed. Considering the tenfold underreporting suggests that many thousands contract Lyme disease in Illinois annually. The effects of misdiagnosis and inability or ineffective treatment can be devastating for people affected by tick-borne disease. If diagnosed quickly, Lyme can be fairly easy to eradicate with simple antibiotics. If undiagnosed or misdiagnosed, Lyme can lead to severe health problems. Only a few that testified this morning about their life-changing encounters with Lyme. However, the number of victims in Illinois are substantial. Many Illinois residents diagnosed with ALS have now found out that they have Lyme. Entire families are affected through congenital Lyme, of which the CDC is just beginning to discuss and IDPH has yet to address. There is a path forward for the state of Illinois. A new way to track Lyme and tick-borne diseases is needed. Cases need to be counted the same as COVID. A positive case equals a positive test. The Council of State and Territorial Epidemiologists revised their criteria to report cases based solely on laboratory evidence without the need to confirm additional information for high-incidence states, which doesn't include Illinois. In 2022, 62,000 cases of Lyme were reported to the CDC, a nearly 70% jump from 2017 to 2019 annual average. We need this new updated reported method implemented in Illinois in addition to the CDC reporting criteria. Illinois would be considered a high incidence state if this new criteria were implemented, and this in turn opened up significant federal funding opportunities. Last session, you passed Senate Bill 1803 or Public Act 103-557, the Lyme Innovation Act. This act is a statewide interagency multi-pronged approach to respond to Lyme and tick-borne disease in Illinois. This act bolsters the capacity needed for the state to address the rapid expansion of tick-borne disease, focusing on public awareness, education, and outreach. The Innovation Act also expands the current passive tick surveillance identification testing program, directed by the Illinois Lyme Association's TREE, or Tick Research Education Evaluation Program, in collaboration with Dr. Stone's lab from PRI INHS at the University of Illinois. TREE is funded through a line item appropriation of $150,000 to ILA. Over time, the passive surveillance efforts will be invaluable for tracking tick disease prevalence in the state, and the recent HHS report completely supports what Senate Bill 1803 set in place, a One Health approach. So senators and representatives, in closing, important legislation related to tick-borne disease has already been enacted because you made your constituents' health a priority and acted. You have put Illinois at the forefront of mitigating tick-borne disease. We have come a long way, but we have much to do. Just as our federal agencies are beginning to focus on Lyme and tick-borne disease, we need our state agencies to follow suit. Lyme disease needs to be a priority for our state through agencies like IDPH, IDNR, and the Department of Ag. Improved disease prevalence tracking and reporting, as well as implementing Public Act 103-557 are critical to the future and well-being of the citizens of Illinois. And I thank you for your time and attention from hearing from the Illinois Lyme Association community today. Thank you.
Thank you. Thank you to all the panelists for sharing your expertise, personal stories, and recommendations with us here today. Are there any further questions? There being no further business, the House Public Health Committee will recess to the call of the chair. The House Human Services Committee will also recess to the call of the chair.
Seeing no further business to come in front of the Senate Public Health Committee, the committee stands adjourned.